officially welcome Dr. Wang to the Parkinson Support Group of Sonoma County.
Thank you all so much for this kind invitation. It is such an honor and privilege to be speaking with you all today on something I'm very passionate about, which is using deep brain stimulation therapy to treat Parkinson's disease. And this will include some of the stuff that's coming down the line, some of the research that my colleague and I are doing to improve therapy for Parkinson's patients. So again, this is my name, and I put my email address in the chat box. So if you have any questions, type away in the chat box. Once I finish, you can also unmute yourself and ask over Zoom, and I'll try to address them as best as I can. All right, this is an outline of my talk today. So first, I will go over what DBS, which stands for Deep Brain Stimulation Therapy, is. And then I will talk about some limitations that presently exist in DBS therapy. Then I will discuss many of the advances that's happened in the past few years in terms of DBS technology, in terms of hardware options that are available, and then talk about something that's very dear to my heart, which is adaptive DBS therapy. And finally, we'll just end with some conclusion marks and answer questions. So as this audience is well aware of, Parkinson's disease is a neurodegenerative condition caused by degeneration of dopamine-producing neurons in the brain, which leads to many of these motor dysfunctions. So patients may have tremor, you may have slowness of movement called bradykinesia. You can have freezing when you suddenly stop moving despite wanting to move. You can have stiffness, also known as rigidity. You can have this shuffling gait, and balance issues and posture issues. And while medication like Cinemet, dopamine replacement therapy, and deep brain stimulation can reduce a lot of these symptoms, it doesn't, address many of the other aspects of Parkinson's disease. So, since this Parkinson's disease is a progressive disorder, in terms of symptoms, it kind of gets worse over time. So when a patient is first diagnosed with Parkinson's, the symptoms may be quite mild and they may not even know they have Parkinson's. But as symptoms progress and affect more and more body parts as well as other systems, the other thing that changes with disease progression is also the response to medication. So, this is kind of a graph demonstrating time on the x-axis and the clinical effects. So basically the orange shaded area means that when medication is effective. So when you first have the disease and start taking levodopa, so dopamine replacement therapy, you may be able to take 1 or 2 doses and you have a good response to the medication, and it controls most of the symptoms throughout the day. But as patients with symptoms that progress over time, the other thing that changes is their response to medication. So basically, medication starts wearing off more quickly, so needing more frequent dosing or increased dosage. And by the time, patients get into more moderate advanced stage of the disease, they develop these motor fluctuations. So medication can, take a while to kick in. And once they kick in, the patient fluctuates between the off state when you're stiff, can't move, to a hyperkinetic state. So meaning too much involuntary movement, called dyskinesia, which is a common side effect associated with medication. And then the medication can unpredictably wear off again. So we have patients, who take medicine every 2 to 3 hours in order to be able to carry on their normal daily functions. So, over time, as disease progresses, the duration of medication shortens and you start fluctuating between kind of the on state and the off state. And as the therapeutic window narrows over time, so basically, as soon as someone is developing these kind of on-off phenomenon and possible dyskinesias, it's a good time to consider deep brain stimulation therapy. A lot of people think, surgery should be reserved as a last resort, but we actually have a lot of evidence and good evidence that when motor fluctuations develop, therapy like invasive brain surgery is actually indicated, and that can really help improve your symptom and improve quality of life. So what is DBS? DBS involves implantation of 1 or 2 electrodes. So usually you require 2 electrodes, 1 on each side of the brain, that targets very specific area of the brain. And this electrode is connected to a battery, also known as pulse generator, which provides the stimulation power to the electrode. And these electrodes are connected to the battery via an extension wire. And there has been, basically 3 targets, brain targets, that we as neurosurgeons can use to provide benefits for patients with Parkinson's disease. One of these FDA approved target is the VIM of the thalamus. So it's an area that's deep in your brain, and this target is only useful in controlling tremor. But if we want to control other Parkinson's symptoms besides the tremor, then the subthalamic nucleus, or the STN, or the GPI globus pallidus interna, those are the more commonly used targets that we implant to treat the motor symptoms. And a lot of people often ask, DBS, what does it do and what can it help? So it can help reduce tremors. It can reduce these on and off fluctuations I was talking about earlier. So basically what it does is increase more on time and decrease off time. If you have dyskinesias, it can reduce that. If you have stiffness, slowness, freezing, shuffling, and as long as these symptoms are improving with medication like levodopa, then there's a great chance that DBS can help reduce these symptoms as well. So these are kind of examples of one of our patients before and after DBS therapy. So before, you can see that she has these very classic symptoms of Parkinson. She has some resting tremor. You can tell she's very stiff. It's hard for her to rise up from the chair. And she has these, short shuffling steps called shuffling gait. And her movements are extremely stiff and slow. And this is after DBS therapy. You can tell that she is able to rise from her chair quickly, walk very quickly. So, she is one of our success stories and has great benefit from therapy. Despite all the things that you see, DBS can definitely help with the motor symptoms, but doesn't help with all aspects of Parkinson's disease. Some things that DBS cannot help with include speech problems. So, things like softer voice, difficulty getting words out. And then some of these other non-motor symptoms like swallowing problems, constipation, drooling, fatigue, memory or cognition problems, and also mood disorders. DBS typically does not help with that. And DBS therapy, what does it involve? So it involves implanted hardware in your body. So that includes a lead extension, pulse generator. And that's what I do as a neurosurgeon. Be sure that I can implant these components safely and very accurately. And then there's an external component. If you have a rechargeable device that requires charger, patients are often given a programmer so you can check your battery level. You can change between different programming settings. And then the clinicians, so your specialists, have access to a clinician programmer that's used to program and adjust your DBS device. So DBS is, in other words, a fully implanted device. The nice thing is that it's reversible. We can always turn it off. And it's also adjustable. So we can program different settings depending on your symptom progression and disease progression over time. But it's also a very complex therapy. It requires a neurosurgeon who, hopefully do a lot of these procedures, who can implant the device safely and accurately. And then it requires a lot of adjustment by a neurologist to adjust the device. So, it's not, one surgery, then you're good to go. It does require multiple visits, throughout your lifetime. But for, I would say, majority, if not all the patients I have implanted, everyone's really happy and said, the device and the therapy can be life-changing. So now I would discuss some of the challenges of DBS therapy. So one thing is the targets that I'm trying to get the brain lead into is a really high real estate area. So think of it as, the Pacific Heights of the brain. So you have also very expensive neighbors that you don't want too much noise or disrupt them too much. So for instance, in the subthalamic nucleus, which is one of the key targets that we use to treat Parkinson's disease, if we get the lead accurately within this location, we can reduce tremor, we can reduce stiffness, slowness of movement, reduce dyskinesia, all the things I talked about before. But right next to this structure is this white matter tract, meaning fiber tract, called the internal capsule. So if I'm stimulating this area, then it can cause problems like slurred speech, can cause your eyes to deviate, so you may have double vision. Actually, stimulation of this area can cause some other abnormal things, like it can actually cause induced dyskinesia itself. It can also abnormally affect some of mood problems and mood dysregulation. So if we can't get the lead in a really, really great location, perfect. But, even if we're just slightly off, and this structure is just a few millimeters across. So it's a very small area target that we're trying to hit. So even if we're slightly off, or, everybody's anatomy is different. So in order to kind of avoid unwanted side effects, one of the current new things that has become available is being able to direct, in the old days, if a lead is suboptimally placed, then you have to have a repeat surgery to replace that electrode. But now with the availability of segmented, also called current steering or directional DBS lead, now we can avoid some of these problems. So the traditional DBS lead, basically you have metal called contact all the way wrapped around this, cylindrical electrode. So when you stimulate that, then the current would spread in a spherical fashion. And it used to be that, we can only march it up or down or change the shape of it. But again, the current would spread concentrically. Now with availability of these directional leads, so a few of these contacts are segmented so they're divided into 3 separate contacts. Now we can not only, march the volume of stimulation up and down an electrode to control, where we stimulate and how much we stimulate. In a second, you'll see in this video here that we can actually control the position and the direction of current by playing around with the directionality, the segmented portion of the contact. So it gives us a lot more control in terms of where to stimulate. So now, for instance, if we're just, near the area of the STM, but not directly within it, we can still, hopefully give patients great therapy by stimulating the STM, the green target here, while avoiding some of the current spread that causes side effects. And so this is an example of some of the new technological innovations that has developed in the past few years that allow us to improve therapy in DBS. And the other thing that I want to talk about now is the invention of adaptive deep brain stimulation, so or also known as closed loop. And I will talk about this in detail. So how DBS works is that we think it restores brain rhythms to a more natural state. So a lot of research has gone into, what causes all these motor symptoms of Parkinson's disease and how DBS works. So we think your brain, kind of just like your heart, has these natural rhythms that are normal, but sometimes they can become abnormal, just like when you have an arrhythmia of your heart. And one, theory about why DBS works is that kind of resets or repaces the brain to a more natural state. So conventional, so normal DBS therapy, standard therapy, the stimulation is on all the time. So basically we set a pretty high frequency. So, you typically over 100 hertz, so 100 pulses per second, that's sending these impulses to your brain. So it's on all the time. And as you can imagine, your symptoms fluctuate, there's a lot of changes that occur during time, throughout the day, with medication, as well as with symptom fluctuation. So you may not need all this stimulation all the time. And one of the other things, that's challenging for DBS therapy, as I mentioned before, is that when we program someone's device, it's actually mostly by trial and error. We can march our stimulation up and down the electrode, change the sphere. But what happens is, after a patient gets surgery, it's an hour or two long programming session with an experienced clinician or provider. And then basically we turn it on and then do some testing to see whether it's working or not. We turn it up and see how much upper limit we can do without causing side effects. And we have to try it for multiple contacts. So now we have these more segmented electrodes. It can make DBS programming extremely challenging and time consuming. So this is an example, fast forward example of our nurse practitioner, Monica, programming a patient's DBS. So, she's kind of turning it on and then basically asking the patient whether some symptoms improve or not, and then doing, testing. And this is a very repetitive trial and error based approach and can take a really, really long time to find the optimal setting. And the other thing I was mentioning before is that sometimes stimulation in concert with medication can actually cause dyskinesia and cause speech problems because there are side effects that can be caused with stimulation. So for instance, this is a patient, when he's off medication, he's doing perfectly fine with DBS. But once he starts taking his medication, now he's developing these bothersome dyskinesias. And so traditional DBS, that's when he may want to turn the DBS off or down to kind of reduce the dyskinesias. And also we can titrate the medication to kind of help with that as well. And then finally, one of the challenges with DBS is that currently it doesn't help with the non-motor symptoms like mood dysregulation, cognitive problems as well. So what are some ways we can do to improve DBS? So as I mentioned just earlier, we're trying to develop these now smart DBS devices. Devices that can automatically adjust the stimulation based on your level of symptoms. So kind of like a heart pacemaker. So, a lot of times with pacers, they're not, depending on the type, it's not on constantly. Basically, it's detecting when your heart stops beating or has abnormal rhythms. And then using these feedback signal, if your heart is beating too fast, it can send stimulation to slow it down. Or if it's beating too irregular, you have a device that can automatically send signals to slow it down or regularize the stimulation. What if we can develop such a system for your brain so that the stimulation is only turned on when your brain actually needs it and turns off or shuts it down when your brain does not need so much stimulation? And so that's why what our lab and my colleague Dr. Starr's lab is trying to achieve, to invent these smart DBS devices so they can automatically and self-adjust. So this is kind of our, I guess, paradigm or model of what we are trying to achieve. So in this, in our studies, we use these specialized pulse generators that not only send signal like traditional DBS, but it's bidirectional, meaning that from these pulse generators, we can actually record or obtain brain signals in real time. And these newer generators can actually stream the signal to a computer in real time. And now we can use, now that we can sample, signals that are coming from your brain, our job as researchers are to analyze what the signals mean. Is it a pathological signal? For example, do we have a signal that only appear when you're having tremors or when you're freezing? And then we build an algorithm within your device that can use the signal in real time and set up new parameters so to reduce and improve symptoms of the disease. So here I'm going to show you a video of one of our patients. He's implanted with this experimental adaptive DBS device. And this is data from my colleague, Dr. Phil Starr, and postdocs and researchers in his lab. So what you're going to see is this patient has these specialized generators available. And on the top graph here is a detector that's built in. So basically, once the orange line down here is the threshold. So we're basically measuring how much dyskinesia is happening. So how much involuntary abnormal movement he's having. And once this detector crosses the orange line, then his device will turn down the amount of current that it's sending to his brain. Because when he's moving too much, we don't want to stimulate his brain even further to cause more movement. And so here's an example. So he's here, moving, doing his regular neurological exam. He has just taken his dopamine medication. And so he's pretty calm, and you can see, the detector for too much movement hasn't crossed the threshold yet. So he's on a good setting that controls his symptoms. And that's what, normal DBS does. So independent of your symptom fluctuation, it's just basically on at a constant current. And then in a short while here, so he's doing great, feeling really well. But in a short while here, you're going to see that he will all of a sudden start developing dyskinesia. So you can see his neck turning a little bit involuntarily. See, he's moving his neck. Now he has these jerks, which is, his dyskinesia. And you can see here now the dyskinesia detector is going off the charts. So now we're detecting this again in real time. And now his stimulation current is being turned down. So before, patients would have minutes or, half an hour of this dyskinesia. But now we're able to turn down his device rapidly just within seconds. And you can see his dyskinesia kind of getting better. So now he's in a good state. And occasionally, there may be breakthrough dyskinesia. And then again, the stimulator is automatically reducing the amount of stimulation to keep him more calm. So, traditionally with patients, this is, called brittle dyskinetic. So they are severe fluctuators. They can go from being super on, hypermobile to frozen. And it's really hard, even though these patients do benefit from DBS, it's really hard to program these patients because with medicine, you just have kind of these unpredictable responses. But now with possible adaptive DBS or closed loop DBS, using his brain signals to control the amount of stimulation we can give him, we can really improve his therapy. And besides things like dyskinesia or a too little movement, the other thing that I'm particularly interested in is using adaptive stimulation, or using brain signals to control stimulation to improve some of these other motor symptoms that are harder to treat with DBS. So as many of you know, gait impairment, so problem with walking, posture, and balance, is a huge cause of morbidity in Parkinson's disease. And they can be unresponsive to conventional, just normal deep brain stimulation therapy. Of course, some patients do have improvements with DBS, but not all patients. And it's a little hard to figure out, who responds and who doesn't. So one of the key questions and that I'm interested in pursuing is how we can improve DBS to treat the gait problems. And I think one of the ways I think about and approach this problem is that gait, human walking, is a very dynamic process. It involves precise coordination of multiple muscles throughout the body between the left and the right side of your brain. So during a normal step, it's very cyclical, repetitive, and rhythmic in nature. There's the thing called the gait cycle, where it's a stereotyped pattern of movement consisting of, heel strike, loading, toe off of one leg, and also it's, out of phase. So just the other leg is doing the opposite thing at all times. So there's stance phase, swing phase, toe off, heel strike events in a typical walking cycle. So one of the ways, I think, because DBS, conventional DBS, is on all the time, you're stimulating both sides of the brain at all time, it doesn't account for this recursive, rhythmic nature that occurs in a dynamic process such as walking. So one of my ideas is that in order to provide improved walking in Parkinson's patients, you probably have to provide stimulation to the brain, each side separately in a coordinated fashion. So my goal is to actually record from the brain during the natural walking cycle, and then figure out, what markers, biomarkers, or signatures are there, whether we can use the brain signals themselves to detect whether you're about to swing your left leg or swing your right leg. And then use that to control stimulation. So we can have coordinated stimulation between two sides of their brain, just like how you're moving, synchronized to your moving. So this may improve some of the gait parameters and maybe prevent your freezing of gait, when you suddenly stop moving despite wanting to move. So as I mentioned before, using these new DBS devices, what we're beginning to see and learn is what happens to the brain during natural walking. And for these research studies, our subjects have, this typical standard clinical deep brain stimulation leads that target either the STN or the GPI, the center of their brain that I talked about earlier. But in addition, we put an electrode overlying the cortex, the surface of the brain. So now we can basically get signal or listen to both surface of the brain and deep part of the brain to figure out exactly what's happening during walking. And believe it or not, because these studies are invasive, we actually just in general have no idea what brain centers are really involved and what the physiology, what the neural signals are associated with normal human walking is. So it also provides a great opportunity to understand the brain circuits and the brain parts that are involved in controlling our walking. So again, we're trying to use these biomarkers of basically the signatures that we find to control stimulation. So how I do this is for patients who have been implanted with a special device, we have them come into our gait lab, so where we study walking. We put external sensors on the patient, then we can really map out, what their body's doing. And if we can synchronize that, meaning, coordinate that with their brain recording, then we can see exactly what's happening to their brain while they're walking. So this is an example of one of my patients. He's just walking back and forth, and we can capture exactly, when he's swinging the left versus the right leg, indicated by, these dotted and solid lines. And this is just time on the x-axis. So this is the top picture is just accelerometer. So basically measures acceleration. So we can synchronize the data between the brain and what we see externally. And then in the middle is data from deep in his brain. And then in the bottom is data from his the surface of his brain. And here's another example of a patient, the same patient, walking. And we can put additional sensors that measure their ankle flexion, extension, and has 4 sensors. So we can really precisely know exactly what part of the gait cycle he's in. And then once we record these activity and we can now correlate it, doing signal processing and analyze these spring signals to know what the signals are associated with leg swing and what signatures are associated when someone's not moving the leg during the stance phase. And what we found so far is that this is a little complex, but these are basically just color plots. The yellow color means there's higher amplitude, blue means that there's lower amplitude for different frequency ranges as shown here. And each little line actually is synchronized to one step or one gait event, about 3 seconds. What you can see is that if we average out, the amplitude of these signals, we can see the brain actually fluctuates and it's synchronized with the gait cycle. So basically what I'm trying to say is that, there are very specific brain signatures that your brain signals themselves dynamically change while you're walking. And using these signals, now we can really begin to decipher what part of walking you're in just based on your brain signal. So this is a patient implanted with electrodes on both sides of the brain. And, we do basically some complex signal analysis and just looking at patterns, what happens in the brain while he's walking. Now, what we can do is build this detector. So kind of like the detector I was telling you earlier, based on the biomarker for too much movement, dyskinesia. This is a biomarker for heel strike and toe off events, as indicated by the different color lines. And this is basically, we can build a model where based on the brain signatures themselves, we can detect with, some 85% accuracy when certain left leg heel strike or toe off and right heel strike and toe off events occur. So the strategy is, again, we're just getting signatures, recording from the brain. We do complex mathematical manipulation and to understand what the signals are doing, and we classify them. And now we can have biomarkers of gait events, kind of like what I've shown you. Now, using these detectors, we can build our own algorithms to stimulate each brain separately to see if we can now improve some of the DBS functions and improvements in gait in Parkinson's patients. And, besides investigating just normal overground walking, we have efforts to understand gait initiation. So that's when you transition from, standing to starting to walk. And also gait adaptation, how someone changes their step pattern, adjust your step size when you're turning, moving through barriers, or when there's changes in environment. So we kind of play this virtual reality game. And this is kind of our setup in which, patients have to adjust their step size to step on these targets while walking on a treadmill. And so in our patients implanted with a special device, we can now gather brain signal while they're doing the task to see what are the signatures associated with adjusting your step size. And we're hoping to, enhance those normal gait adaptation signals. And so now I'm actually involved in a clinical trial where we capture walking events from patients at home. So we give patients these devices that they can wear around their ankles and capture, a lot of their gait measurements while they're just moving about their daily activity, while we can record and stream their brain signals, and using that to control stimulation. So, in short, I think there's so much advances in terms of DBS technology. There are infinite number of things we can explore, and it's a really exciting time for us in this field. I like to thank my lab, my colleagues at the Movement Disorder Neuromodulation Center, without whom this would not be possible.